Hello and welcome to this educational video short brought to you by the Campbell University Drug Information Center. This episode is all about some of the most important treatments that we utilize in heart failure, namely our evidence-based beta blockers and ACE inhibitors. So tune in, sit back, and take it away, Dr. Bowers.
So within our core therapy, the first drug that we're normally going to start on a patient are ACE inhibitors. ACE inhibitors or ARBs. We're going to use those interchangeably. ACE inhibitors are recommended in all patients with HFrEF with current or prior symptoms, so we're talking stage C, unless contraindicated to reduce morbidity and mortality. So on our little chart, ACE inhibitors are going to be the first drugs in our mortality-reducing agents. So they reduce morbidity and mortality. Now, ACE inhibitors are going to give you mortality benefit even at their starting dose. It's an important note, write it down. ACE inhibitors, even at their lowest doses, are going to give you mortality benefit. So at 2.5 of lisinopril or 40 of lisinopril, you are getting mortality benefit. So it's important to get your patient on an ACE inhibitor. So ACE inhibitors give us hemodynamic benefits in patients with HFrEF. They decrease pulmonary capillary wedge pressure or preload, but they also decrease systemic vascular resistance, SVR, or afterload. Getting those reductions in preload and afterload helps prevent that progression of left ventricular remodeling. And what you will usually find, drugs that prevent progression of left ventricular remodeling reduce our mortality risk. So that's going to be a recurring theme. They also give you functional improvements. So ACE inhibitors have been linked to functional improvements as well. Clinical pearls. So when to start an ACE or an ARB. So this is going to apply to ARBs as well. When we're talking about initiation, usually this is one of the first drugs we're going to initiate. Now, if I have a brand new heart failure patient with a reduced ejection fraction, I'm going to try to start them on an ACE, a beta blocker, and a loop diuretic as needed, all at the same time. We try to get them on all of step one, if we can. In patients who are over-diuresed or very dry, we have to be careful about starting an ACE. Because those are the patients that are likely to go very hypotensive. Now, they have to be very, very dry or in a significant AKI for me to not start an ACE, because you can go to very low doses. The very low doses of ACE inhibitors still give you mortality benefit. Yes, we do want to monitor for that rise in serum creatinine. How much of a rise is okay in that initial time period? 30%. So we're just going to expect that. As long as we don't have a huge jump, a doubling of serum creatinine, anything that meets that definition of AKI, we're okay. Because you're eventually, long-term, going to get renal benefits from using that ACE or that ARB. So we do have to monitor for that. One time that I would be hesitant to start an ACE or an ARB is if a patient is in AKI. Now, if your patient is CKD, do you start an ACE or an ARB? So chronic kidney disease? Yes. I have a heart failure patient that serum creatinine is 3. That's really high, but it's always 3. Been 3 for the last 3 years. That's a stable chronic kidney disease patient. That patient is going to get mortality benefit if they have HFrEF from being on an ACE or an ARB. So I'm absolutely going to start that patient on an ACE or an ARB. The opposite would be if their serum creatinine, when I see them, is 3 and it's normally 1. In that patient, if they had HFrEF, I would wait for that acute kidney injury to resolve. It doesn't have to resolve fully, but it does have to be on its way to full resolution before I started that ACE or an ARB. Because of the way they work in the renin-angiotensin system, they also have that blockade of aldosterone, and anything that's going to have a blockade of aldosterone can also cause hyperkalemia, so increase in potassium. ARBs have the same indication since the 2017 guideline update, and we're going to practice from the most recent guidelines, as ACE inhibitors. So it's ACE or ARB, in this case as step 1 therapy. ACE or ARB. ARBs are recommended in patients with HFrEF with current or prior symptoms who are ACE inhibitor intolerant and less contraindicated to reduce morbidity and mortality. What's one of the common ACE inhibitor adverse effects that you can get rid of by switching to an ARB? Cough. Very good. What about if they have non-life-threatening angioedema? Can you switch to an ARB? Yes, we're going to go with yes. If you have a life-threatening allergy to an ACE, would you switch them to an ARB? No. No, we're not going to do that. Even though the cross-reactivity is very low, if it was a life-threatening event with the ACE inhibitor, we would not, in that case, switch them to an ARB. ARBs, like ACEs, do not have a dose-dependent mortality effect, so get them on your ACE or an ARB, even if you have to start them on and leave them on the lowest dose. That is okay. All right, let's move into beta blockers. So beta blockers, we have for HFrEF evidence-based beta blockers. Our evidence-based beta blockers that have been proven to reduce mortality are bisoprolol, carvedilol, and metoprolol succinate, not metoprolol tartrate. Bisoprolol, carvedilol, metoprolol succinate, so our extended release metoprolol. Recommended for all patients with current or prior symptoms of HFrEF unless contraindicated. So all patients should be getting an ACE or an ARB and a beta blocker. Beta blocker is the next part of our core therapy. Beta blockers, you absolutely need to know the doses. You absolutely need to know the doses because the mortality benefit is dose dependent, which means you want to achieve maximally tolerated beta blockers. That should be a goal, to get your beta blocker dose to either the maximum or the maximum that your patient can tolerate. The higher you get the dose, the more mortality benefit you will get. Don't go over the max. Here, carvedilol 3.125, and you can go up to 50. I will tell you most patients will be maxed, and by most I mean 90% or more are going to be maxed at 25 milligrams BID. You can also use sustained release carvedilol. Beta blockers, we know, hit our beta receptors, but they also do a lot more in the body. One of the things that they do is blunt that sympathetic outflow. So by doing that, they can decrease oxygen demand and increase supply. Very, very important when we talk about ischemic heart disease. Through their effects on cardiac function, they've actually been shown to help increase our ejection fraction. That's good. We want that ejection fraction to come back up. Decrease in the left ventricular volume, and they help the left ventricle achieve a more physiologic shape, so they prevent that remodeling. And what happens when we prevent remodeling? We decrease mortality. Beta blockers have also shown to have improvement in functional capacity and symptom control. This may be the most important clinical pearl that I covered today. Probably is, because this comes in play much more frequently in heart failure patients who are typically volume overloaded than the ACE when we're talking about volume depleted. So timing of initiation. Remember I said in an ideal world, we're starting all of the core therapy at once. In an ideal world, we're starting them all. We want to avoid initiating beta blockers when patients are volume overloaded, because that can actually lead to heart failure exacerbation. That can actually decrease cardiac output. However, if they're already on an established beta blocker, you don't stop it. So that's the next slide, or the next section. Avoid discontinuing chronic beta blocker therapy when the patient presents to the hospital with signs and symptoms of exacerbation, especially in the presence of a low output state. So we don't want to DC that beta blocker if it's stable and they're on it. Beta blocker should ideally be initiated shortly before discharge. That's because most of your patients are in exacerbation when they come in. And then we need to counsel them about the beta blocker blues. That's kind of what that last bullet is describing. Dr. Herring talk about the beta blocker blues at all? Has anybody talked to you about the beta blocker blues? So think of beta blockers kind of as slowing everything down. They're slowing down the heart rate, and when you slow down the heart rate, the heart actually gets to spend more time in diastole. The heart is the only organ that perfuses while in diastole. So while the heart is relaxing, it's perfusing. It spends more time in diastole when the heart rate is slower. But because we're slowing that rate down, your patients, when they start out on a beta blocker, can often feel very sluggish. They can feel very sluggish because up until the start of that beta blocker, they've been used to running, 80s, 90s, maybe even the hundreds on their heart rate. And once you get used to that, once you slow it down, everything feels very, very slow. So that's what's described as the beta blocker blues. It is transient. It will go away, but it's something you need to absolutely counsel your patients on, because if they feel sluggish and they feel bad, what are they probably going to do with their beta blocker? Stop taking it. So you got to definitely talk to them about the beta blocker blues.
We hope you enjoyed this educational video short brought to you by the Campbell University Drug Information Center. We hope you found the information helpful, interesting, and most importantly, that it helped you understand this topic better. We'll see you next time.